Dear friends, a very good evening to you all. I am Dr. Madhuri Mehta from Hisar, Haryana, and I am thankful to Dr. Weber for organizing such an interesting webinar, though it is started a bit late. Dr. Weber kept it quite late, and my Indonesian friends must be having some problem viewing it so late, so we are sorry for that. But I started this. This is a series of 7 lectures on facial nerve, seventh facial nerve, and is it visible, Weber?
Yes, we can see over.
Okay, so what happened is I have already presented the facial nerve anatomy lecture to my Indonesian delegates. You know what happened last year in September? I went to Spain for a facial nerve symposium. It's a big conference, happens every 3 to 4 years, and there I met those Indonesian delegates, and they really requested me that I give all those lectures to them online. And in between, you also asked me, so I have collaborated the two. I hope I'm able to impart something new to you all. So Dr. Diana is also there with her delegate. Good evening, Dr. Diana. I hope they're all awake. So without causing much delay, I will start with my first lecture. Okay. It is a series of 3 lectures. Okay. I will share. Okay. So, for a patient, facial palsy is a very debilitating condition. It can lead to severe cosmetic and functional disfigurement and can cause mental trauma to the patient. Out of all these facial palsy cases, most of them recover on their own and completely, spontaneously and completely, but few of them really require some further treatment in the form of this medical or surgical treatment. Objective measurements are certain valuable tools to understand what kind of treatment is needed for the patient. We mark out which are the patients who are for medical treatment and the others for the surgical, and which surgical technique, when to do. All this can be done when we have done a proper evaluation, planning, objective measurement, and management strategy. So for me, treating a facial nerve is a passion, and I every case I make a full detailed analytical graph and then go word by word to what I have formed for that patient. So I am that particular about every patient. For a patient, we ask where, when, how, and how much is it affected, the facial nerve. And for us, it is when, how, and how much can I correct it. All these things you have to have in your mind before you go ahead and do a surgery or any treatment for facial palsy. And facial palsy here, I mean grade 6 facial palsy. So there are planning tools today we are going to discuss, which includes evaluation, management strategy, and surgical rehabilitation technique, counseling, and outcome tracking. All 4 points form the planning for me. Evaluation consists of history, clinical examination, topographic evaluation, but these days, from last so many years, I have stopped doing it because of their false positive and negative results. I'll tell you how. Then imaging in the form of CT and MRI. Those two imaging tools are the most important for us in this present times. And then there's electrodiagnostic testing. Believe me, they are required in very limited cases and they are important there only. So we are not doing it in every case. So coming to history. When I take a history, the moment patient enters into my OPD and I see there's a facial paralysis, the first question comes to my mind: onset of the facial paralysis. I'll ask the patient how it started. Was it sudden? It will give me an indication, okay, it can be viral or idiopathic, or it was post-traumatic roadside accident, or it is something like associated with some chronic SOM or some iatrogenic. So onset will give me the idea firsthand what is the case I'm going to deal with. Then degree of facial palsy. Was it grade 6 from the very start? whether presently it is grade 6, where was it 5 or 2 or 3 and became 6 on later on, or it was 6 grade 6 and come down to grade 2. So many things. The moment you start asking open questions to the patient, they will guide us through the this diagnosis. And then comes the most important thing is duration. Duration can be the patient could have reached us after a long time, like 3 months, which is the cutoff line for the best treatment, has already passed. That is what I call golden period, 3 months. I'll tell you why. So that is already passed, or the patient has come directly to us. So duration becomes very important, and the time period between facial palsy and the patient's first visit to me. He could have visited some other surgeon or some other doctor in between. I will get every details from him, whatever papers he is carrying, I'll put it properly. And one by one, I will go through all the detailed documents he has, and then I will form my this thing, analyze how it fits in the present situation. Then etiology. Etiology doesn't play much of the role in deciding the surgical technique and when to do. Etiology just gives us the insight into the disease what patient is suffering, because usually facial palsy for us is such a big thing that we take it as a single entity, whereas facial palsy most of the times is part of some bigger disease, some different disease, and etiology gives us that insight, so that we are able to know what we are going to do and how we are going to treat the patient in the present scenario. Then I will ask whether it was unilateral or bilateral facial palsy. Bilateral facial palsy is a very important entity. uh, Believe me, I have a series of 18 bilateral facial palsy cases. Almost 15 of them are post traumatic facial palsy, fracture both sides of the temporal bone. Then one was a syndromic child, Moebius syndrome. The other was recently I had a vaginous granulomatosis. So it will also tell us whether it is the upper motor neuron or lower motor neuron. If there is, he says the forehead is sparing. So all these questions are important. Then we can ask the alteration in taste or lacrimation, just to know the level of involvement. Then any symptoms of underlying or associated diseases, like etiology can be something traumatic or iatrogenic, but there could be associated diseases like diabetes, kidney problem, or skull base osteomyelitis, whatever. We have to have a very detailed history taking from the patient. And the most important is past history. Patient has come to me for the first time for facial palsy, but did he have or she have any episode in the past, which will guide me, okay, repeated recurrent episodes could be fitting into facial nerve schwannoma. Past history is equally important as the present history. All these I'll just pass through the etiology, just to keep you to give you in your mind that there's so many conditions when the patient comes for the first time to us. All these conditions should go through our mind, that we are going to rule out each one of them. If it is intracranial, it could be iatrogenic, neoplastic, congenital, like Moebius syndrome, I told you. Because if I see that it is a congenital disease, Moebius syndrome, facial nerve does not form here. So, no use doing some primary repair. It is always a free muscle neurovascular grafting done. So, all these etiologies can guide us what kind of treatment I'm going to give to the patient. If I go to intratemporal etiology, it is mostly traumatic, which is the roadside accident, fractures of petrous pyramid, or some penetrating injury or iatrogenic injuries. Neoplastic can be in the form of cholesteatoma, acoustic neuroma, facial nerve neuroma, hemangioma, meningioma. Uh, Infections can be herpes, acute, chronic, or malignant otitis externa, idiopathic. And if we go to extratemporal, there can be post injury, traumatic, iatrogenic, newborn paralysis, and neoplasms like parotid tumor, tumor of the external and middle ear, facial nerve neuronomas, metastatic lesions, and congenital absence of facial musculature. Just to make you go through all the list, now we come to the clinical examination. We do, once I have a detailed history, my mind has already started working in certain direction, that what where it is leading me to, whether it is traumatic, which part, it is forming in the mind. Next comes clinical examination, which is a step by step examination for localization of disease, severity of lesion, and functional deficits. For this, I will do proper complete ENT and head and neck examination, general physical examination. ENT and head and neck examination is very important because once we see facial nerve paralyzed, we get so much focused on facial nerve that rest of the things become less important to us. Whereas it is very, very important to examine rest of the head and neck area for any other indication or any other part of the disease. And then we do general physical examination for to see whether the patient is suffering from some any other disease like autoimmune disease, diabetes, or any kidney problem, because all these conditions could be related to the facial nerve palsy. Then proper neurological examination, and it is a complete detailed examination because we have to rule out that whether it is an upper motor neuron lesion or lower motor neuron lesion, or was it a post-injury facial or post-traumatic facial nerve palsy, whether he has received some kind of neurological treatment somewhere else. We may be dealing with a case with meningoencephalocele or meningeal herniation or encephalitic herniation post-traumatic. There's so many things we have to keep in mind. Then we do evaluation of lower cranial nerve functioning. There was an interesting case I had few months back. It was a bilateral NF2 bilateral acoustic neuroma patient. There's a young girl, and she was operated on one side somewhere, and gamma knife was given on the other side in, I think, Medical College, Rohtak. The side which was operated developed complete grade 6 facial palsy. So just to improve upon that, I wanted to do some kind of, because inside the ear and intratemporal, all the facial nerve was gone. The surgery was so wild. So I was thinking of doing facio-hypoglossal anastomosis. And I was about to decide for that surgery. I just did a lower cranial nerve functioning examination and did CT MRI, and I could see that hypoglossal nerve was also involved in this neuroma. There was this neuroma involving the hypoglossal nerve. So facio-hypoglossal was not the right treatment for that. So please evaluate because we may be needing these cranial nerves for our repair. Then central or peripheral facial palsy, again upper motor or lower motor neuron type of lesion, because in central it is always contralateral and upper part of the face is spared. Then comes the most important part, which is clinical analysis of face at rest and during 7 volitional movements. I'll tell you how we check it. After that, we do grading of facial palsy. Usually, most common is House Breckman's classification. The other more important and more authentic are Sunnybrook's grade system or E-face. I'll tell you in the next slide. Then we take proper photography, videography to document appearance at rest in 7 volitional facial movements. How we do that? We have to do clinical analysis of face at rest, then wrinkling the forehead by lifting eyebrow, then light closure of eye, then tight closure of eye, nose wrinkling, smile for lower lip depression, and puckering of lips. All these are to be done to cover upper, mid, and lower part of the face. Now I'm showing you 3 videos. Just see. This is first video.
ऐसे ऊपर कीजिए, ऊपर माथे को ऊपर कीजिए. ठीक है, आंख बंद करो, कस के और कस के. ठीक है, नाक चढ़ाओ. ओके, आंख खोलो, नाक चढ़ाओ, ऐसा. वेरी गुड. मुंह में हवा भरो. ओके, ई करो.
So you can clearly see this is a grade 6 facial palsy left side. It was an interesting case offered to me in Mumbai, some conference in Mumbai for doing surgery in a conference. So this patient, we got a CT scan done, everything done, and we were unable to find the site of fracture line. We usually try to look into the intratemporal part for that. This is a case of roadside accident. So we kept looking for fracture in the temporal bone and could not find it. And then we went just before the start of this surgery. We went to the radiology room, sat with the radiologist, and then suddenly, in the lowermost cuts, she saw some fragments of bone. So we thought where the injury is. Then we asked the patient's attendant. They said when he fell down on the ground, there was a stone hitting at the pre-auricular or under the left pinna. So he had suffered the injury on facial nerve once it was out of stylomastoid foramen, and we were looking for the fracture line inside the intratemporal part. So this was operated nicely, and it was to be operated, and I did a repair in the neck only. So important thing is, had I seen this patient before, I would have examined the neck to see the site of injury. That could have given me the hint. So don't take any case lightly. It may be telling you more than what you can see. Now see this patient.
ऐसे ऊपर कीजिए,
Sorry.
ऊपर, माथे को ऊपर कीजिए.
Oh, this is a case I received.
आंख बंद आराम से,
Just look at
आंख बंद आराम से. ठीक है, अब आंख जोर से बंद, पूरी जोर से बंद.
just mild closure with great pressure. You can see it is a case of bilateral facial palsy. He is unable to put furrows on the head. No nose wrinkling, no smile, nothing on the, he has a mask-like face. Now this patient I operated on the right ear almost 4 years back. He came to me with the left ear chronic SOM with grade 4 facial paresis, left side. So I was thinking of operating on this patient because seeing facial nerve paresis or palsy, it gives us sudden kick that I'm going to treat this patient. So I took up that case, and I was thinking of operating on him. I did a HRCT temporal bone. There was slight funny kind of wetness in the ear, which gave me an indication that something is not right. There should be some either tubercular or some granulomatous disease had to be there. Just 2-3 days before I had to operate this case, he came suddenly to me with complete bilateral facial palsy, lower motor neuron lesions on one side, and kidney problem and whatnot, liver, all the investigations all were deranged. Then he was finally diagnosed to be a case of Wegener's granuloma. Now he is taking chemotherapy for that. So unless until you know what you're going to see, you don't know what is the case, you will not be able to do justice with the facial nerve. Don't be in a hurry. Always take out time to find what case is there in your plate. Now look at this case. Eye closing, but not completely. The forehead furrows are not there. Lip completely, lower face is completely paralyzed. So in which grade do we put it? It is not grade 6 because eye is closing, but it is incomplete grade 5 and 6. So at times House Breckman classification doesn't fit every case. And this was a case, it was a case of iatrogenic facial palsy where previous surgeon had operated. And when I opened it up, there was continuity of 10% fibers which were supplying to the eye. And that's why eye could be closed and rest of the face was like paralyzed. So if we talk about this, then clinical grading scoring systems, presently existing grading systems are insufficient. House Breckman classification cannot explain this kind of facial paralysis. House Breckman grading system is what we follow. Most of 95 to 98% people all over country and rest of the world are following House Breckman grading system. More authentic is Sunnybrook's grading system, and more than that, there is a digital now grading system coming up, which is called eFace. So House Breckman grading system was developed in 1985. It is a very generalized kind of grading, very easy to do. So everybody is following this, knowing very well that this does not completely explain certain situations in facial nerve paralysis. It is very generalized. Grade 2 and 3 are muddled up. We many a times are unable to differentiate between grade 2 and 3, and many a times between 4 and 5. Grade 1 and 6 are okay, clear. In between, because there is no scoring, no range of scoring, nothing, it is not there. Face at rest has not been calculated, though still we are following because this is the easiest one. Looking at it after 15 years of this, a revised version named Facial Nerve Grading System 2 was introduced with few improvements. Here it was done in 2009. The facial zone, face was divided into 4 zones, and the movement were given certain numbers, movement score. Then sin kinesis was also quantified and a score was given. So total score calculated on that, the grading was done. It was quite, much better than the previous one. Though at rest, again, it was missing. At rest, the face at rest also gives us many information which is not included in the modified House-Brickman grading system. Then comes Sunnybrooks grading system that is quite good and suffices most of our requirements. It has been divided into 3 parts. One is resting symmetry score, RSS, then voluntary movement score, VMS, then sin kinesis. Because we are always talking about the voluntary movement of the face, we're not talking about the resting symmetry. And almost every case, when it is improving and recovering, can go through sin kinesis or other complications, and that score is also to be kept. So advantage of this is it is simple and easy to use, describes the patient's facial function in details, quantifies the recovery in different parts of the face, because if we keep doing at different phases of recovery, it quantifies the recovery. It does not require any special equipment and can be used as prognostic tool due to its accurate sensitivity to clinical changes. So this is a graph which you can use it, very easy, very informative. Resting symmetry, voluntary movement, synkinesis, they are given numbers, and then this is multiplied by 5, this is 4, and this is total number. But one limitation in this was left was resting symmetry has not been scored like the voluntary movement and synkinesis. So two things which is making it less in use is, one is it is less prevalent than House-Brickman's classification. Even if everyone is trying, we are not getting over the House-Brickman's classification. All of you after this lecture can go back home, try to fill up that form with the patients. It will give you so much information, so much more information. But here also the symmetry at rest should have been scored by a range to reflect the changes more accurately. Though if we go to E-phase, when Dr. This Diana knows, Dr. Diana knows that when we went there, Dr. Tessa Hedlock, this was the world's most renowned ENT and plastic surgeon from America, was talking about E-face. It is a digital parameter. It is called Electronic Facial Paralysis Assessment Tool. It consists of 16 items in a visual analog scale format that can be converted to a static, 5 items, dynamic, 7 items, and sin kinesis, 4 items domain score. So 3 parts have been done at rest, dynamic, and sin kinesis, averaging out into a total score ranging from 0, which is total paralysis, to 100, which is normal facial function. This much range is available there, and it is advantages. It is including detailed analysis of static and dynamic assessment. It does sub-regional scoring, high-resolution synkinesis scoring, sensitivity to change, convenience of digital data. We can have our data, all the cases there, and in a click of a mouse, we can have all our data there on the screen. Then it has high intra-observer and inter-observer reliability, high test-retest reliability. But this is not available properly still. It is costly thing, and we have to pay a lot to get this software for this e-face. It will be coming soon, will be available. Coming to topo diagnostic test, I am not doing it. It is usually done to locate specific site of lesion, and I think nobody is doing these days. All these tests were done, but now this topographic evaluation has lost its relevance over time due to high chances of false positive or negative results, which are mostly due to extension of inflammation on both sides of site of injury. So we are not doing it. Coming to imaging, CT and MRI. Now some part of the facial nerve is in the bone and some are in the soft tissue area. So HRCT temporal bone is the most important to define the course in the intratemporal region. And we do axial coronal sagittal planes, and CECT, contrast enhanced CT, if suspicion of neoplasm or vascular abnormalities are there. What it does, it evaluates anatomical course, abnormal facial nerve, abnormal location and caliber of nerve in different pathologies. Many times you see widening in that area or narrowing in congenital stapes. It can be showing lower down of the facial nerve. So HRCT is a very good tool. Most of my diagnoses are based on the HRCT temporal bone. It also evaluates the dehiscence in the facial nerve, fracture line, erosion, destruction, or widening of fallopian gland, like in small neuromas. Many cases I've seen the facial nerve neuroma. It is so small that we miss it on clinical judgment, and when we do a CT, we can see the widening in that area, and it confirms on the MRI. So HRCT is the basic investigation is to be done in every case. It also tells relationship of facial nerve with surrounding structures like ossicles, cochlea, and vestibule. MR sequences are done for intracranial and extratemporal segment mostly, because does not give much information about intratemporal, though we perform this MRI mostly with the CT scan. So T1, T2, plane with contrast, cis, flare, that depends on the situation what we are looking for. It evaluates the soft tissue abnormality around facial nerve like inflammatory diseases, tumors, malignancies, facial nerve tumors, and anomalous course of the nerve. All these situations can be seen on MRI. In neck and face, it evaluates the involvement of facial nerve in parotid tumors and malignancies. So if we consider right usage of imaging, for supranuclear lesion, standard MRI brain. For nuclear lesions in brainstem, high resolution CT scan and T2 weighted MRI. For lesions in CP angle, IAM, and labyrinthine segment, both HRCT, T2 weighted and contrast enhanced T1 weighted MRI images through interauditory meatus. If we come to the temporal region, till its exit at stylomastoid foramen, both HRCT, temporal bone and skull base, and MRI with gadolinium contrast. Here, contrast is used when we are in the intratemporal region. And soft tissue CT with contrast or MRI can be used to evaluate distal course of facial nerve within the parotid and soft tissue of face. For evaluation of tumors of facial nerve, both MRI and HRCT are performed. So mostly they are hand in hand, but these two are the most important investigation we do in our cases. Coming to electrodiagnostic testing, many a times people are confused. Why are we doing? What information do they give us? They are slightly less understood. Basically, they are done to determine the severity and prognosis of a facial nerve lesion. Severity, which means that it tells us whether it can improve or recover on its own, or does it require surgery. And prognosis is when we do it in a regenerating stage or long-term facial palsy. Few situations are there we need these tests. Like these are performed in cases of idiopathic Bell's palsy, which is not improving, post-traumatic facial palsy, long-term iatrogenic or infective facial palsy, which is where the facial palsy is existing for more than 3 years, whether any treatment is going to, primary repair is going to give some benefit or not. It is done in hemifacial spasms, neoplastic lesion of parotid where infiltration of facial nerve is suspected. The electrodiagnostic test becomes the first sign of nerve degeneration, even when the facial nerve palsy has not presented. So, in that case, we are able to counsel our patient that we are going to face facial palsy once we do the surgery. In those cases, electrodiagnostic tests are important. Also, it clearly differentiates a central facial palsy from an incomplete peripheral facial palsy that spares the upper face. So electrodiagnostic test is required there. There are two electrodiagnostic tests we are doing. One is electroneurography, which is ENOG. It analyzes the evoked compound muscle action potential of a specific facial muscle, like this nasolabial or nasalis muscle, and it compares the action on from normal and the affected side after transcutaneous placement of the electrode near the trunk of facial nerve near the stylomastoid foramen. So this is compound action potential where all the fibers are firing together. That compound action potential is noted and it is compared to the opposite side. So it always needs the opposite side to be normal to compare. It is best done between 3 to 21 days post onset because Valerian degeneration starts after day 3 and completes till the 21 day. So this is the period where we can do this test to know whether the nerve is really transected or degenerated beyond repair and surgery is needed. So how it works? The bipolar electrode stimulates the facial nerve at stylomastoid foramen. The compound muscle action potential, where all the neurons are firing together, are recorded from this muscle, and this amplitude which is recorded, the sum up of all the action potential, is the recording proportional to the number of intact axons. It shows the amplitude. This is a normal amplitude. This is a abnormal amplitude. So the height of it will show how much are the intact axons. And the two sides are compared as percentage of response. So result, how do we analyze the result? So one of the primary goals of ENOG testing is to identify patients likely to have good or poor outcome without some type of intervention. Less than 90% degeneration within 3 weeks predicts 80 to 100% spontaneous recovery. At least ENOG completely clears those cases where there is less than 90% degeneration, that they are going to recover spontaneously, no surgery is needed. If it is more than 90% degeneration, it is a poor prognosis. So chances are that we need to do surgery there. It can only differentiate grade 1 conduction blocks, which is neuropraxia, from grade 2 to 5 block, which is axonotomesis and neurotomesis, but it cannot differentiate between 2 to 5. So this is an incomplete test. It always needs EMG with it to clearly tell that whether a surgery is needed or not. It can tell in cases less than 90 degree that the surgery is not required. But if the degeneration is more than 90%, it requires EMG, because when regeneration of nerve fibers is happening, axons start firing at different time and pace, and the compound action potential becomes inaccurate, and it starts showing more than 90%. The graph becomes flat. Though regeneration is happening, it is giving wrong information. So it is performed with EMG. So surgical intervention is needed where ENOG degenerates by 90% and no volitional EMG is recorded. EMG is directly the muscle action potential recording. So both together can tell us whether it is going to recover on its own or needs some surgery. I hope I am able to make you understand what is these tests are. So coming to electromyography is the direct recording of spontaneous and voluntary motor unit action potential by introducing needles into mimetic muscles, facial muscles, or surface EMG. Lately, surface EMG has come into action because needle is slightly, painful for the patient. We record motor unit potential of four muscles like frontalis, orbicularis oculi, orbicularis oris, and mentalis. So all four muscles, their action potential is needed, but it is most helpful from 2 to 3 weeks to up to 3 months after the onset of palsy. Like ENOG could be done between 3 to 4 days to 3 weeks. It can be done from 2 to 3 weeks up to 3 months because final degeneration at the muscle level reaches after 2 to 3 weeks. What are the different responses of EMG? In a normal resting muscle, biphasic or triphasic potential every 30 to 50 milliseconds happen, even if when there is no action happening. Whereas if we get a polyphasic potential, it indicates that regeneration process has started. In these cases, surgical intervention is not needed. So polyphasic is good after an injury, which shows that the nerve is regenerating. If there are fibrillations, it indicates motor neuron denervation happened, but viable motor end plates are okay. So surgical intervention can be done to achieve nerve continuity. Here, surgical intervention will give benefit. Whereas if there is an electric silence, that indicates atrophy of motor end plates and need for muscle transfer process. So this fibrillation will show primary repair is going to pay well, whereas electric silence means that muscle fibers are atrophied and it may not be very beneficial to do primary repair. We may need to do some added static or dynamic procedures. So EMG relevance is studies suggest that patients with Bell's palsy or temporal bone fracture cases with 90% or greater degeneration on ENOC and absent muscle unit potential on volitional EMG in the acute phase are at high risk for poor recovery. And here we need to do some surgical correction. And EMG is also useful in prognosis of long-term facial palsy, which is more than 3 years. If it is already 3 years and EMG is giving a silent graph, then mostly primary repair is not going to help. In those cases, we definitely should combine primary repair with dynamic or static procedures. This was the evaluation. Now coming to the management strategy. We have done all the tests. Now how to go further? Conservative or surgical? Which surgical technique? When? What synkinesis? Prognostic criteria? So these are the conservative situations. We're not going to talk about that. We are going to talk about surgical procedures. How to choose a procedure? Once it is decided that surgery is to be done, how to choose a procedure? It does not depend on etiology. It depends on two very important factors. How to choose a procedure? One is availability of proximal stump. The disease or injury, if has caused loss of proximal stump of the facial nerve, then situation becomes totally different than the availability of proximal stump. The second is time period elapsed. These two are the most important factors which make us decide which technique and when to operate. Time period is divided into three categories. One is less than 18 to 24 months. Second is 24 to 36 months with EMG positive. EMG positive is a very good indicator that the primary repair is going to help. But if it is more than 36 months, which is 3 years, and EMG is silent graph, that means the primary repair is not going to give much benefit. So this is a flow chart. It's a very complex situation. So flow chart to describe how time period and proximal stump help us in reaching a conclusion. It is divided into two categories. One is less than 2 years or 2 to 3 years with EMG positive. This is more than 3 years and EMG negative. So these are two groups. In these two groups, if the nerve, there is only compression or slight injury to the nerve, we do decompression. Now again, two categories. Here the functional proximal stump is available and here proximal stump is not available. If we have a proximal stump available and less than 2 years or 3 years with EMG positive, we will do primary repair, end-to-end anastomosis if both ends are available, or free nerve graft if the ends are not close to each other. And if there is no proximal stump available but still less than 3 years EMG positive, then we do motor nerve transfer in the form of fascio-hypoglossal or fascio-mesenteric anastomosis. And plastic surgeons do cross-face nerve graft. They take the buccal branch from the normal side, put a sural nerve in between and take to the opposite side of the affected side. Buccal to buccal is done. This is a favorite procedure for the plastic surgeons. And this is a very good fascio-hypoglossal and fascio-mesenteric anastomosis, giving good results when the proximal stump is not there and another motor nerve is required. If it is more than 3 years and EMG is negative, still my practice is that I always try to perform the primary repair, but with that I add dynamic procedures like free muscle, gracilis muscle neurovascular graft, or muscle transposition or elongation like Labis technique, temporalis elongation or masseter transposition. And if we have done a good primary repair, we can add static procedures in the form of upper eyelid implant or the slings. So if you look at it and make in a mathematical approach, you will find that every case fits into certain situation and you know what to do with that. Now coming to counseling. Counseling is very, very important in our practice for facial nerve. We have to educate our patients before surgery regarding the slow progress even after best management. And then not so good recovery of involuntary emotional expressions. We have to tell our patients that emotional recovery may not happen because the injury, whenever there is a complete transaction, the emotional expression doesn't come back very easily. Then various patient-based scales have been developed over the time, which is called prompts. I'll tell you about them. They are to be shared, and patients should know how to assess their facial nerve involvement. So, what is ideal outcome measurement panel? Before and different stages after management of facial palsy. We do assessment before and then different stages after management. It has been divided into one patients reported outcome measures. Patients tell us how much recovery is there, and there are three indexes for that: Facial Disability Index 1996, Facial Clinimetric Evaluation Scale 2001, Synkinesis Assessment Questionnaire. These are important ones. You can read it in the books, literature. Then clinician grading scoring system, which I told you in the start, HBC, Sunnybrook classification, and the E-phase. Then comes objective assessment tools. Just imagine our predecessors who were good surgeons. They had big name in the country. Even I went to Mario Sana. There also he was not going to that detail and extent about facial nerve. It was given, okay, house Breckman grade 2 or grade 5, okay, this much recovery has happened, good for the patient, good for us. We never considered what is going to happen, how much is the recovery, which fibers are improving, sin kinase is happening or not, what we are doing to avoid sin kinesis or mass movement. So many things are coming and people are doing so great a work. This objective assessment tools are photography, videography, facial clima, emotrix, and then layperson assessment tool. Another third person is telling the recovery in the form of attractiveness, eye tracking, disfigurement, and then spontaneous smile assessment is done. These all are things are done by plastic surgeons because they have to give back the best to the patient. So here I finish my first lecture by saying that learning is like taking birth again and again till the last day of our life. And I am doing it every day. This is a painting I made many years back. Every day I feel that the day is opening like a egg and I am taking rebirth again and again. Thank you very much. Hello?
Yes. Wonderful first lecture, madam.
So can I go to second lecture? I hope people are keeping awake because this was the most, I will take the third. So can I start with the second lecture?
Yes, definitely.
This is one of the lecture I presented in the Spain Madrid facial nerve symposium, where the topic is the title is Management and Prognosis of Iatrogenic Facial Palsy in Middle Ear Surgery. My 25 years experience. Facial nerve palsy or the iatrogenic facial palsy being the most deep debilitating complication, all ENT surgeons avoid causing it. They try their best. For that, I will say that this is a constellation of 7 stars. It is called Ursa Major, or in our Indian scripture, it is called Saptrishi, 7 stars. I remember in our childhood days when we were growing up playing in the grounds, our mother will suddenly say, look at the sky above and look for the Saptrishi. And we will, within seconds, we will find amidst trillions and billions of stars, we could locate this Ursa Major or the Saptrishi. That is how our eyes should be trained for the facial nerve. If you make me stand anywhere in the garden, in the room, and ask me, I will create the structure of facial nerve anywhere. That is my passion, my obsession with facial nerve. And that should be yours because it has to be in your mind. Before you cause a trauma, you have everything in your mind, then you cannot cause trauma to it unless until you develop that much love and passion for facial nerve, you're not going to get good results. So, iatrogenic facial palsy can be part of lateral skull base surgery, middle ear and mastoid surgery, and any surgery on face, in neck for brachial cleft anomalies or in parotid surgeries. So, I am taking up because this will become too big a lecture. This I am talking about only middle ear and mastoid surgery. So, overview of this lecture is why it happens. We are going to talk about it. Then management protocols, then surgical procedures for different situations, observational study at gyms, which is by institute, and conclusion. So factors attributing to iatrogenic trauma, which whatever I could collect were like if there is already some destruction or distortion of landmarks for identification of facial nerve, the surgeon gets lost while operating and can cause trauma. Then there are cases where there is anomalous course or anomaly of facial nerve, which can be dehiscent, bifid, or trifid. And if some surgeon has not even imagined it or has not seen such cases, has not done enough temporal bone dissection courses, they will they tend to miss it. Then comes the displacement of ossiculoplasty processes or cartilage used for posterior superior canal wall reconstruction. If there is a dehiscent facial nerve beneath it, they can cause facial paralysis. Then faulty operative techniques and equipments, which include quality of microscope, drills, machines, and burrs is not up to the mark. Improper size of burr for that given area, because when we are rubbing our burrs on the fallopian canal, we always say take the biggest burr for that given area, and no small size burr should be rubbed there. Cutting burr in places of diamond burr. Whenever we come close to the fallopian canal, we always should immediately shift over to a diamond burr. Then there can be direct mechanical trauma from tip, side, or shaft of moving burr or heat generated from drilling. That happens with novice surgeons when they are doing a canal wall down. The sudden rubbing can cause so bad a trauma to the tegment bone, facial nerve, internal ear, semicircular canals. All these can go in one single go. Then it can be because of improper size, quality, and use of suction tips. We have been using over the years sometimes very big sized, sharp edged, worn out suction tips. They can cause trauma to the dehiscent facial nerve there. Then comes to most important ones are insufficient knowledge of surgical anatomy of facial nerve and concept of disease. New surgeons coming up, even the already practicing one. We stop updating ourselves with the latest concepts. We stop doing some temporal bone dissections for the further knowledge. We don't know the surgical anatomy of facial nerve, and then we think of treating it. That is the biggest, misconcept we have, and not sufficiently trained surgeons. I would request everyone. This is my teacher, Dr. KP Morwani. Otology, most of it I learned from him, and he taught me how to love the facial nerve passionately. We have done so many things, this workshops and this together temporal bone dissection courses, and I have learned a lot from this. And I advise everybody of you to get to do as many as temporal bone dissections as possible. So, what are the misactions of the surgeon? He can do injury at the first genuine level, but he can also Is it I am audible because my light had suddenly light had gone. Okay, thank you. So, what can happen while doing surgery is most commonly when we are operating on a child less than 4 years, then there can be injury to mastoid segment in the stylomastoid foramen. Hello, am I audible?
Can get your voice, ma'am.
Okay, done. So in when canal wall up mastoidectomy, many times I have seen surgeon poking the instruments from the posterior epitympanotomy side. Medial to the incus, we have to be really very careful because there 30% cases of this 30% cases there is dehiscence of
Madam,
the tympanic segment. Hello,
we are not able to see your screen.
you're not seeing?
Yeah.
Okay, I will reattach again. Okay. Is it visible now?
No, not yet.
Is it visible?
No.
Not visible? It says that I am sharing the screen. For 1 minute, the light went off, and suddenly on my side, I am able to see. Are you not? Is it not visible?
No.
Let me first stop sharing and then do it again. Okay.
Okay.
Now,
No.
what's happened? Okay.
Yes.
Now it is visible.
Yes. Perfect.
Okay, sorry for this inconvenience. Okay, so basically we have to see that we don't poke sharp instruments there, causing trauma to the facial nerve. If we are unable to find the space, it is better to take out incus rather than poking the instrument blindly. In cases where there is so much anteriorly placed sigmoid sinus or low-lying tegmen, while creating space there, we can cause trauma. Then this is the most important slide which I want every one of you to see. Whenever we are doing a cortical mastoidectomy, just below the short process of incus, there is a buttock formation, like prominence there. The facial nerve becomes slightly take a bend posteriorly and then becomes lateral. So this is the area where most of the injuries happen. This many a times while locating the antrum, they go slightly down rather than here. They start drilling here. Now this is a case I am showing you. There's a fellow with me who had come. There are two tables in my OT. I was operating on other and I gave this case to him. And there was tympanosclerosis in the superior part. You can see this is the posterior part of the incus. This is short process of incus. This is incus bridge, left side of the patient. So instead of drilling here for the antrum, he started drilling here. And I was listening to the sound of the burr, and I could feel that this burr is going on and on and on, and is not stopping. There is no change in the sound of the burr. That gave me a feeling that he is rubbing against very hard bone. I immediately came there and I found that instead of locating for antrum there, he was locating it here. This is what he could do. There was an injury to the lateral semicircular canal. There was injury to the facial fibers there. He had created antrum there. So I did a complete decompression there beyond the site of injury, repaired this lateral semicircular canal, and still the patient suffered facial palsy for 3 months altogether. So we have to be really, really very careful while doing surgery. And I have done almost 30,000 years surgeries, but till date, I can get some case where there's a lot of sclerosis there, tympanosclerosis, sclerosis of mastoid cavity, and I can also get lost. So what I do is I look inside the middle ear, I look for the incus, and close to the head of the incus and the towards the top, I would see that I keep close to that. And second is sinodural angle. If I keep towards this, I'll not be lost unless until I keep these things in mind. I am going to get lost there even at this stage of my career. Injury can also happen dehiscent, as I told you. If there is a dehiscent or decompressed facial nerve, we are doing ossiculoplasty. It can get it fall on the exposed nerve, or when I'm placing the posterior canal wall reconstruction, the cartilage can get dislodged and sit over it and cause facial palsy, but delayed one. Then, in cases of extensive tympanosclerosis, you have to remember in your mind whenever there is this extensive tympanosclerosis, it is going to be tympanosclerosis of promontory and facial canal also. And beneath that big plaque, there will be dehiscence in the promontory and dehiscent facial nerve. So don't keep taking out the tympanosclerotic plaques from promontory and facial nerve. We can free our ossicles from the tympanosclerotic plaques, but no need to disturb the facial nerve because underneath is the dehiscent nerve and we can cause trauma there. Now this is posterior tympanotomy in cochlear implant. If I am going and doing, you can see this is the almost slightly anteriorly placed mastoid segment of facial nerve. Holding the burr like this, the shaft is going to definitely cause trauma there. So we have to be careful wherever there is facial nerve, keep the shaft of the burr away from there. Then in cases of stapes surgery, whenever there is a congenital deformity case, anomalous course of facial nerve, this is left side, the facial nerve is covering the foot plate. So while lifting this, we can cause trauma. Here, this is bifid facial nerve. While doing surgery here, we can cause trauma to the facial nerve. So we must read our CT, we must know what we are going into, what is our case, and then only do the surgery. Now, this is a very important this image what I'm going to show. Whenever some surgeon is doing canal wall down mastectomy, a slight mismanaged burr here can cause trauma to the tegment, causing the meningoencephalocele. And while I reduce the meningoencephalocele, just see how badly the facial nerve is traumatized there. And here the burr can also cause injury to the lateral semicircular canal. So canal wall down is, we always prefer inside out mastectomy rather than outside in, because in inside out mastectomy we keep moving away from important structures, whereas in outside in we keep going towards important structures, so causing trauma there is more chances are there. So we always follow the inside out technique. Also, we can cause trauma to the vertical portion of the facial nerve. And this is an anomalous cause. It's a cholesteatoma in a microtia case where can you see, this is cholesteatoma, canal wall down. This is the area where the facial nerve should have been. This is lateral semicircular canal, and I could locate it here. Can you see this? So unless until we know our case, we don't know what are anomalous locations, we don't know what is the congenital anomaly, we don't know the destruction or the presence of the important landmarks, we may cause trauma to the facial nerve. This is just the bifid facial nerve. All these are my collections, and I am very particular My eyes are trained that before even the facial nerve appears, I can feel that the facial nerve is around. That tissue, the look of facial nerve should be in your eyes. So if I talk about iatrogenic facial palsy, how we go about such cases, the management. One is intraoperative recognition. This is another flow chart to tell the algorithm of the management of facial palsy, because it is a complex situation, and unless until we have a mathematical approach of treating these patients, we will get lost. So this is a very beautiful flow chart which can explain how to go about it. Iatrogenic facial palsy, a surgeon can know intraoperatively, as I showed you in the previous case, that I could know there is injury happening to the facial nerve, or it is a post-operative recognition. If the intraoperative recognition, surgeon knows that the injury has happened, as in the previous case, there was injury to nerve sheath and less than 15% of fibers. What we will do is there and then only do nerve decompression on both sides of the injury, release the nerve edema so that the nerve recovers. It is going to give grade 6 palsy once the injury even to sheath or the less fibers, because nerve has suddenly reacts very badly. So it will be grade 6 palsy, and unless until we do nerve decompression. Some surgeon called me few days back that this has happened, what to do. I told him that do decompression here and here now, otherwise the facial nerve palsy will take a very long time to recover. So this is what is to be done. This is slight injury, but if it is transection has happened, if it is partial 15 to 50%, we do either realignment of disrupted fibers or use partial thickness nerve graft between the disrupted fibers. Never leave them like that. If it is the transected part has got lacerated, then cut away the lacerated fibers and put a partial thickness nerve graft. Another is near total transaction. All these videos I'm going to show you to correlate the things. Near total means more than 90, almost 90%. Again, previously it was said cut all the fibers and do end-to-end anastomosis, but my take is, in my cases I've seen, I must maintain even a 5% intact fibers. If they are healthy, I will maintain them, because they may be supplying to an important part of the face which will continue it functioning when the rest of the graft is going to provide further supply. Because if I cut those fibers, then that part of face has to start again. So that functioning keeps going. So never cut the remaining fibers. And if the transaction is complete, it is total transaction. If the ends are close to each other, we'll do end-to-end repair. If possible, do rerouting so that we only do single neurorephy, single anastomosis, because single anastomosis can give grade 1 facial recovery to the patient. If we put a free nerve graft in between, then recovery is not more than 2 or grade 3. So try to achieve single neurorephy or single anastomosis, even if we have to reroute the nerve cut ends. Rerouting can take away some bit of this vascularity of the nerve, but still it is better than putting free nerve graft in between. Now, if the surgeon comes to know about it post-operative, immediate, post-operative, late. Post-operative recognition, immediate. There could be side effect of local anesthesia. Then the surgeon should wait at least 4 to 5 hours for it to subside. In between, he or she can think whether he done any trauma to the facial nerve. If he can identify that the trauma has happened or the trauma has not happened, if the surgeon is confirmed that the nerve is intact, then you can keep observing with serial electrodiagnostic tests. If tests are unfavorable for 2 weeks, explore with decompression. And if you think these tests are okay, keep waiting, the nerve will improve. But if the facial was not identified in surgeon, the surgeon says that he has not touched the fish, he doesn't know, then it is dangerous, because unknowingly somewhere he has caused trauma. Here, immediate surgical intervention is required by the same or more experienced surgeon. If unknowingly facial nerve injury has happened, please don't wait. Try as early as possible, because you won't believe within 10-15 days so much fibrosis happens. You will be surprised to see any case where it is only 5-10 days old injury and there's lot of fibrosis and hypertrophy tissue happening there. So try to take action as immediate as possible and proceed according to the intraoperative algorithm as I told you. Now, patient, the first surgeon did not know that he has caused injury. The patient has reached second otologist. Now, the second otologist should tally the operative notes, imaging, ask the previous surgeon if he can give any input, any surgical notes there, and immediate surgical intervention is to be done if there is no clear-cut notes. And if post-operative recognition very late to the same surgeon, which means there must have been some dehiscent facial nerve, and any persistent infection has caused late facial paralysis. These cases usually improve after we take a good culture sensitivity, give the right antibiotics and steroids. These improve on their own. These are the most important ones where we have to take action immediately. So once it is decided that surgical re-surgery is to be done, what we do? Decompression, facial nerve repair. As I told you, if the ends are available, end-to-end anastomosis. If the ends are not closed, then interposition, partial or total nerve grafting. If somewhere injury has caused so much loss that the proximal end is not available, we'll do motor nerve transfer with fascio-hypoglossal and fascio-mesenteric anastomosis. And this is the primary nerve repair. It can be combined with dynamic reanimation procedures if it is a long palsy, with muscle transfers, free muscle flap with microneurovascular anastomosis. And then if we have done primary repair and we expect that there was a total nerve grafting has been done, and it is going to take almost 2 to 5 years for the nerve to repair, we cannot let the eye suffer. We will do upper eyelid implants or weights, static slings, and tissue rearrangement like Botox surgery. Because whenever we use a grafting, this recovery can take almost 2 to 5 years. So we must combine them with static procedures. We all know I will show video for each situation. Decompression is also called as neurolysis. Whenever there is injury to sheath, nerve sheath, minimal fibers are traumatized. What we do, drill the fallopian canal around the site of injury, expose the nerve for few millimeters beyond the site of injury on both the sides, incise the nerve sheath and release fibers from intra and extraneural scar tissue. Scar tissue is to be released if we want the axons to regenerate or grow properly. If there is active infection, then sheath is to be kept intact and address a neuroma which has formed. Mostly you will see when there is injury cause iatrogenic injury to the facial nerve, you will find a neuroma formation, and you won't know what to do of that neuroma. Either cut it and do end-to-end or grafting, or leave it like that. So neuromas are very important to address. What are post-traumatic neuromas? They form in response to injury like laceration or penetration to facial nerve, and they indicate axonotmesis or neurotomesis. It is grade 2 to 5, not grade 1, not grade 6. The axons are going through them, but how to deal with them, I will tell you. Post, why do neuromas happen? Post injury, there is shrinkage of nerve sheath, over proliferation of endoneurium and Schwann cells from proximal end to neural reinnervation. If the regenerating and proliferating proximal end meets the scar tissue, continuous proliferation leads to neuroma formation. So neuromas are a haphazard arrangement of small nerve fascicles containing axons, Schwann cells, and perineusal cells with surrounding fibrosis with no distinct myelin sheath. So all things are jumbled up. What kind of neuroma we find? We must know. Whenever we do take up a case of iatrogenic facial palsy, the direct injury to the nerve can cause fusiform, bulbous, or dumbbell shape. There are two types of neuroma. One is neuroma in continuity, where the nerve is continuous but neuroma formation is there. One is end-on neuroma, which I'll tell next in the next slide. Here, there could be slight inflammation. Very few fibers have got formation of neuroma or fusiform. In these cases, you don't take away the neuroma, you just remove all the scar tissue and fibrosis around it. You can see it here, and you can get grade 1 recovery. There can be lateral exophytic neuromas, like injury through the fallopian canal has caused injury to the minimal fibers there, and they form a cauliflower like appearance. If we cut them, again we can treat. The nerve remains like that only. Then come dumbbell neuroma, dumbbell shaped. Here, what happens? Injury is slightly more. It is so bad that in between it, the nerve has got literally thinned out due to fibrosis, and there is a dumbbell shaped neuroma on the proximal side and distal side also, like this. Okay, and then comes the normal nerve. Here, this, if you think that this is going to work, it is not going to work. Here, the nerve fibers are not going to grow, and you are never going to get result, and patient gets only one chance, and he has given that chance to you. So you must know how to treat them. Go beyond the both the neuromas, reach up to the healthy part, cut that much nerve in between, and put a graft there. Don't wait for self recovery in these cases. Then comes end-on neuroma. End-on neuroma, there is the nerve is completely cut, and there is a neuroma at the end. So in this case also, go beyond the neuroma, reach the healthy nerve, cut it there. The gap may be more. Don't worry, it will take slightly more time to recover, but it will recover to a great extent. But if you don't do it justice, if you put a graft there without removing the neuroma, believe me, the recovery is, because there are not healthy fibers, this is all scar tissue there, so it will, recovery will not happen beyond grade 3 or 4. So this is one surgery. This is a iatrogenic facial palsy, operated somewhere else. Came to me, there was a lot of infection. I gave culture based antibiotics, did a surgery. You can see that. It's a grade 6 facial palsy, left side. Treated the patient with steroids and antibiotics, nothing happened. Then I opened up the case. This you can see, completion mastectomy has been done. Here the tympanic segment has been traumatized by the surgeon. So what I'm doing is going on both the sides, not disturbing the continuity of this neuroma. First I exposed, I at first I thought this has got a transected facial nerve, because I could not see the normal facial nerve around, and very gentle lifting of bone around and doing a good decompression would show me that, just see how beautifully the nerve has come up. Now I am taking away all the fibrosis and scar tissue around the neuroma. Can you see? Slowly and gently the nerve is coming back to its normal shape. This is the proximal side. Now I have exposed normal nerve on that side, proximal as well as the distal side. So beautifully the nerve has expanded. Just see. Post surgery 6 months. She could be improved to grade 1. So I believe that whenever neuromas are treated nicely, we don't have to cut them, they give 100% recovery back to the patient. This is the post surgery situation of the year. Such nice wide canal and complete recovery. What can you ask more from such cases? Now, this was a decompression. Now coming to partial transection of facial nerve right side. Whenever there is partial transection, remove the lacerated margins and put a partial thickness graft in between. You can see this is again a iatrogenic case. This patient came to me, I operated. It seemed that the two cut ends are there. This is stapes right here. But when I went beyond, always develop this habit of going beyond the site of injury on both the sides, reach the normal plane of the nerve, and then only explore here. So when I went around, I could see that this is 50% of the fibers are cut, 50% are intact. So injuries can be to any extent. It is like accident, can be to any extent. So what I did was I cut away all the both the lacerated margins, kept the nerve intact and put a partial thickness graft there. On one side, I put a suture with 80 monofilament, and other side, I put glue. And you always do what when we are placing a graft, cover the area with a piece of perichondrium on both the sides. Another case, this was a very interesting case. Again, it was given to me in one of the workshops in Mumbai, TraumaCon. And this patient was operated around 15, 20 days, I remember, by some surgeon. And again, he said, I have not gone close to the facial nerve. And that is what our teacher told us. When the surgeon says he has not gone close, that means unknowingly has caused injury. Now, this look at this face, you don't understand how much injury is there. Eye is closing nicely, but rest of the face is paralyzed to grade 6. So I took up this case, left side canal wall down mastectomy, and when I was exploring, I could see these torn out pieces lying there. It was quite bad. This is the mastoid segment, second genotympanic segment, how bad it is. And just before I show this video, I want to tell this is the intact fibers. Still, some fibers of the muscle, this nerve was intact. And when I took a sensory nerve, this great auricular nerve, to repair this defect, the great auricular nerve was very thin. So I made a loop out of it. This is called double graft. So both ends are sutured to one side, and I give a cut here, and the other end is sutured to this side. You can see. These are the lacerated margins. Go beyond the lacerated margins and reach the healthy nerve fiber. The gap may be big, but this is a great auricular nerve. Now it was so thin. So I created a loop out of it, took the measurement there. And when I'm using it as a loop, what I'll do is I'll cut the intact margin there, because it is going to be used as a tubule through which the nerve fibers are going to grow. So it has to have a raw end there. So now this is being placed between the two cut ends, and I could put the glue there. Important thing is the approximation should be very good, because from proximal to distal, the nerve fibers are going to grow through this tubule only. So now some small pieces of perichondrium have been kept, ossiculoplasty done. Now this was a case I had, she is in Mumbai. So I kept asking her husband to click pictures and videos and send it to me. This was, I think, post surgery 6 months. Though the improvement is there, but the patient doesn't seem happy. This angle of mouth has not improved. This is post-surgery 1 year. Just look, the look has improved. This pleasant look on the face. The patient is happy that she is improving. Just see the smile. Nasal wrinkling has appeared. The smile is closing towards normal. So I was not expecting this good a recovery, because this nerve was very bad. Anyway, so that was partial grafting. Now comes complete transection leading to two cut ends. Then we do end-to-end anastomosis. This is called neurorephy. What we do is reapproximate or reroute the cut end of facial nerve with end-to-end repair. Cut ends are trimmed to have healthy fibers. There should be, whenever we are putting anastomosis, end-to-end anastomosis, there should be healthy tissue bed medial and lateral to the anastomosis. Either apply suture by 80 monofilament or glue. No undue tension should be there. Both ends should be nicely meeting each other without tension. Adequate soft tissue coverage laterally. So this is one of the case. This is anterior. I was doing a case of anterior transposition of facial nerve left side for glomus tumor. Just see. I had released the nerve. I was just trying to, this early days of this thing. You can see this right side, this facial nerve has been exposed till the first genu, and I was about to lift it up. But here one branch in the neck facial nerve remained intact. That had to be cut, which I did not cut. And while lifting, it led to, to total toning of the facial nerve. So when the moment I came to know that the injury has happened, I put the end-to-end anastomosis through 80 monofilament sutures. I want to show you that I have placed a muscle there medial to this anastomosis because, as I said, in the starting 4-5 days, the anastomosis takes its vascularity from the surrounding tissue. So there has to be some pedicled soft tissue graft beneath, medial to the anastomosis and lateral to it as well. So this is what I'm placing medial. And laterally, again, another muscle, both muscles are there to provide vascularity. And you can see good improvement has happened. So don't shy away if there is an injury to the facial nerve. Take care there and then only so that you don't give long-term facial palsy to the patient. Now, if the cut ends are not close to each other, there is a gap in between. So we have to use interposition nerve grafting. But the limitation is that there are two neuroraphies, two ends of anastomosis. So the nerve has to grow through this longer graft to reach the distal end. It takes longer time, and recovery also is not as good as in the end-to-end anastomosis. Here, what we do is we cut ends of facial nerve and free up for a few minutes on both the sides. Then we take this interposition nerve grafting is done with the sensory nerve, like great auricular nerve or the sural nerve. If it is a small graft, we take great auricular nerve. And if it is, we need long graft or multiple branches, we take a sural nerve. The edges of the graft should be elliptical and bevel shaped because we want maximum area to be facing the cut end of facial nerve so that maximum nerve fibers grow through them. The cable graft should be of optimal length. It should be lying in S or C shape after final anastomosis like this. It should not be tight single, 10% extra lying in a lazy S or C shape manner so that nowhere the anastomosis is under tension. The perfect matching diameter should be there. Ends of facial nerve and cable graft should be nicely reapproximated. Suture or glue at the anastomotic sites. Wrapping with perichondrium. Healthy tissue bed. Soft tissue coverage. That is what is required. Just see, this was another case. Another of my junior who was operated, he said, I have not gone even close to the facial nerve. And it was around almost 20-25 days after primary surgery. And he had done the same thing, drilling through the facial nerve in the mastoid segment. These are the cut ends you see. Lazy S-shaped graft between the two and perichondrium wrap. I'll show the video for this. Very small video. Rather than looking for antrum there, he started looking for the antrum slightly down and just drilled through the facial nerve. This is the lower end of the facial nerve. This is the upper end of the facial nerve. The lacerated margins are cut. This is cutting in bevel shape. Great auricular nerve. These are small perichondrium pieces placed around the anastomosis. The approximation should be really good. If we are using glue, then approximation really matters because suture can place the approximation nicely, but when glue is being put, then the approximation should be good. Then we wrap perichondrium around it. We provide a support there for the anastomosis to grow, and that is how it is. Spend a lot of time here because the patient has, again, I say, got only one chance. Kindly give him that chance properly. Then this is facio-hypoglossal anastomosis. I think these are another lecture. I will not go into the details for that. End-to-end or end-to side. It is a very long topic. I cannot be taking in facio-mesenteric anastomosis. Whenever there is the proximal end is not available, Then we locate for the masseter nerve there, bring it on the surface. This is the cut end of the facial nerve at the stylomastoid foramen. We take it up and put a suture between the two. So this is another faciomessetric anastomosis. Now I'll talk about observation study at gyms. In last so many years, I've done 48 patients of iatrogenic facial injury, primary surgery done at other centers. The primary surgery was done for either cholesteatoma, tubercular mastocytosis, or sculvus osteomyelitis. Revision surgery, including surgery on facial nerve, was performed by me. So just wanted to show you what are the types of injury happening. Before revision surgery, which I did, the 87% ranked HB grade 6, 13% ranked HB grade 5. Per operative finding, most of them, 50% had mild injury, 45% had partial to complete transection, and 4% has multiple segment fibrosis. And surgeries performed were decompression in 50% cases, end-to-end anastomosis in 8%, partial grafting in 4%, single cable grafting in 29%. Now see, I want to take your attention here. Mostly injury was mild, but other than that, cable grafting was required in more cases because injury causes laceration of cut ends, and so there is a gap in between. So end-to-end anastomosis in lesser cases and single cable grafting in more cases. Then double cable grafting in 2 cases I showed you, fascio-hypoglossal fascio-anastomosis. So this is final recovery was 47.92% recovered to HB grade 1, 16% recovered to HB grade 2, 29% to HB3. Again, this matches with the interposition nerve grafting. Usually, we get recovery up to 3 or 2 only, and 6% recovered to grade 4. So, conclusion is the segment affected most in iatrogenic trauma is tympanic segment, followed by second genuine tympanic segment together. Site can be confirmed by preoperative HRCT. In all surgical procedures, prognosis depends on extent and duration of injury. Mild injury with duration less than 3 months gave the best results up to grade 1 with decompression and end-to-end anastomosis, grade 2 with partial or total interposition. Duration more than 6 months compromised on recovery going from 1 to 2 or 2 to 3, or if duration more than 1 year, even up to grade 4. So duration becomes very important. As early as possible, do the repair so that we get better results for the patient. Duration more than 2 years gave poorer grades of recovery. So thank you for your kind attention. I think this is the book you must have read. Vaibhav,
Yes.
awake or all are asleep? I don't know.
We are awake. We are well awake, and you can hear also the applause from the audience.
Thank you. Was it okay?
Wonderful, wonderful.
Okay. So now first I will go to the post-traumatic.
Yes. So we will wind up, as early as possible the third lecture, if it's okay with you.
20 minutes.
Yes, that's perfect.
Okay. And otherwise, we can take it later on also, third lecture, if you say so. You ask people.
As we are okay, as long as we finish in time.
Okay. Then I'll do it fast.
Yes, yes, yes.
Okay.
Okay.
So, I will go directly to facial nerve injuries in temporal bone. Facial nerve is the commonest cranial nerve involved in road traffic accidents. Risk of facial, I think this we can leave. 6 to 7% of temporal bone fractures cause facial palsy. 25% are immediate onset complete paralysis, and 75% are incomplete delayed facial palsy. They remain unnoticed if the patient is admitted in hospital with other grave injuries. So these patients usually reach later to us. Implications can be really bad. it becomes our prime duty as otologists to correct them. I don't talk about this. So, okay, coming to overview. How to assess for etiology and extent of injury, investigation and CT scan, all these one by one. I will take very fast. Assessment. 5 important factors are there which allow us to assess how we are going to go about to take up a case. A patient has come to me. Time of onset, degree, time of first visit, as I told you in the evaluation time. If it is immediate, complete, grade 6, chances of self recovery is less. We will have to need some surgery. And if it is a delayed incomplete palsy, we will wait for some time for this to improve on its own and do certain investigation. Time of first visit to otologist. If already patient has come 3 months late, the golden period is over and we need to work fast. Otherwise, we can wait for some time and do certain, give some steroids and conservative treatment for this to recover. Extent and location of injury. This CT scan is very important because it shows us whether it is a longitudinal transverse or mixed fracture. So I will focus mainly on this. Even more than the electrodiagnostic test, if we know how to read our CT scan, we will know the diagnosis very well and know what to do with them. If there are associated vertigo, CSF leak, conductive mixed hearing loss, then even grade 5 will require surgery because this means either inner ear is affected or tegmen is gone. Surgery is the treatment of choice when this is very important. Please pay attention. Immediate grade 6 facial palsy with CT scan showing fracture line transecting fallopian canal. This is 100% indication for surgery. Immediate complete facial palsy with fracture line transecting the fallopian canal. Next is CT scan is showing bony fragments impinging on facial nerve. If CT is showing so, please don't wait, please don't wait. Bony fragments are not going to dissolve, they're going to traumatize facial nerve unnecessarily, causing permanent loss. Third is delayed grade 6 facial palsy, not recovering or improving in grades in 3 months. I will tell you why. Next, facial palsy less than grade 6, not improving further in 3 months. Even the patient has come with grade 5. It is not grade 6, but it has not improved to grade 4, 3, or 2 in the 3 months. Again, it is a condition for surgery. Doubtful time of onset of palsy when the patient comes, but the present grade is 6. Again, it is for surgery. Facial paresis with additional symptoms requiring surgery like vertigo, profound conductive mixed hearing loss, CSF otorrhea, then even paresis will require surgery. And bilateral facial palsy. As I told you, I have 18 cases out of 15 cases have got bilateral facial palsy post injury. They are in bad state, mask like face, tears flowing, saliva coming out, unable to close the eye, smile. They are really in pathetic condition. At least one side needs the surgery immediately. So, why 3 months? Because once there is injury, axonal sprouts push out from proximal stump within 4 days. Start seeking the distal end at the rate of 1 millimeter per day. Proximal and distal ends best approximated without scar tissue till 30 days. Early repair helps axon to grow into collapsing tubules, thus expanding them. If we do it early, the growth will be through the natural tubules. After 30 days, regenerating axon sprouts have to pass through distorted scar tissue, and this is called a collagenization. So, what is collagenization? It is progressive shrinkage in axon diameter over 3 months, along with gradual thickening of collagen in the endoneural layer. So, axon is shrinking, the surrounding endoneural layer is thickening. So, the axon does not find a way to go further. So, it has to go through the scar tissue. So, the growth stops. So, many of the fibers which could have reached the distal end get lost through the scar tissue, and we are never going to get recovery from them. So 3 months is the optimal period after which the the results are not that good, because after 3 months they say that there is change in biology of facial nerve nucleus at the central level also. So always consider 3 months as the cutoff line. So we do audiometry, HRCT, temporal bone, electrodiagnostic testing. Now let me show you. HRCT temporal bone shows whether it is a transverse or longitudinal fracture related to long axis of temporal bone, petrous bone. Another classification is otic capsule sparing or otic capsule disrupting fractures. So what is longitudinal fracture line? When there is blow to the temporoparietal region, it involves the squamous temporal bone. Posterior superior wall of the external canal passes through mastoid and over the tegment in the region of facial hiatus, but it is in the direction of facial nerve, so does not transect it. Whereas the transverse fracture is occipital blow. This is sideways blow. This is occipital blow from foramen magnum across perpendicular to the pyramid of this bone, and it passes through the otic capsule, through the facial nerve and floor of middle cranial fossa. So complications in transverse fracture is facial palsy is 2 to 4, 5 times more common, CSF leak 4 to 8 times more common, SNHL 7 to 25. So this fracture is more dangerous than the sinister than the horizontal. So just see, these are the longitudinal fractures going along the axis of pyramidal bone, sparing the inner ear, sparing the facial nerve. Just see, it can be like this. It can, in bilateral facial palsy, it can be going like this on both the sides in all these directions. And I can see you on the CT also. Now this is a bilateral facial palsy. Here this is slightly oblique two sides fracture line. This is again a horizontal or longitudinal fracture line. Again a longitudinal fracture line. But in these cases, the fracture line was keeping lateral to the middle ear. So not dangerous. They will improve on their own. Whereas here you can see the fracture line, though longitudinal, is going as medial as possible. And it is affecting the facial nerve at the first genu. This is labyrinthine segment. And there's lot of fibrous tissue and bony fragments sitting there. So this case, I cannot put for this conservative treatment, because this bone piece is sitting on the first genu and it needs to be lifted up. So this is even if when it is a longitudinal fracture line, the surgery is needed. If we talk about transverse fracture line, it is occipital blow from behind. So it foramen magnum cutting across the this petrous bone, like in different directions. Here the injury, it cuts through the inner ear, cuts through the facial nerve at the this. You can see through the CT also. The longitudinal was like this. This is transverse. It is cutting through the this facial nerve at the first genu level. You can see it here also. Labyrinthine segment is gone. So whenever there is a transverse fracture line, most common affected part is labyrinthine or the first genu area. So we must know how to decompress that. So surgical intervention is definite in cases of transection of facial nerve, trauma causing inflammation, intra or extra neural hematoma, contusion, compression, partial trauma to a dehiscent facial nerve. Fibrosis has developed in and around the facial nerve, bony fragment sitting. Now just see, this is the facial nerve and this is bony fragment sitting there. This inflammation cannot settle down unless until I take away this bony fragment. So the surgery for this case. So how we decide for the selection of technique and approach? The extent of injury decides the procedure what we are going to do, and site of injury decides the approach. So read it nicely. Extent of injury decides the procedure what we are going to follow. Site of injury decides the approach. So talking about extent of injury and selection of procedure, if it is a contusion, stretch, hematoma, fibrosis, decompression is good enough. If there is a bony fragment impinging on the facial nerve, removal of fragment with decompression. But If there is transection of facial nerve, already told you, end-to-end anastomosis or grafting, and long-term facial nerve palsy, we have to add either dynamic procedures or static procedures along with the primary repair, and adjuvant procedures with Botox or physiotherapy. Decompression I've already shown you. Transection I've already completed in the previous lecture. Coming to selection of approach, we already discussed in previous lecture that procedure is based on the extent of injury. Now selection of approach. The international criteria is how they decompress a post-injury facial nerve palsy. They pick up middle cranial fossa for labyrinthine segment and first genu, and transmastoid approach for tympanic segment, second genu, and mastoid segment. Usually they use combined approach, both middle cranial fossa and transmastoid, to start from labyrinthine segment up to the stylomastoid foramen. But a common ENT surgeon, otologist, doesn't know how to do a middle cranial fossa approach, and they don't get the training for that. Only a lateral skull surgeon can do that. So these facial palsy patients post injury come to a normal ENT surgeon. So how can he do the surgery? Just see the limitation of middle cranial fossa approach. When we retract, we have to retract the temporal bone to expose the first genu and labyrinthine segment area. So chances of injuring, just see, it is this superior view of the left ear. This is internal meatus, labyrinthine segment, geniculate ganglion, greater superficial petrosal nerve. So whenever I come from above, I can cause injury to the superior semicircular canal. I can cause injury to cochlea. I can cause injury to internal meatus. So this is not a very good approach. The approach which I follow is, there are three approaches which I follow. Transmastoid posterior tympanotomy for vertical portion decompression. If there is a supralabyrinthine corridor available, which means it is a cellular mastoid, I can do decompression of labyrinthine segment also from here. Can you see in this picture? And other is transcanal, like inside out approach. And third is, we have devised with Dr. Morvani, transzygomatic anterior rectic approach. We go from front and directly reach the labyrinthine segment from the zygomatic arch side. So taking each procedure one by one, it will hardly take 10 minutes now we will finish. This is transmastoid posterior tympanotomy supralabyrinthine approach. People still go by mastoidectomy side to reach the labyrinthine segment, though it is too far off. While going there, I can cause trauma to the lateral semicircular canal, superior semicircular canal before reaching there. And if it is a sclerotic mastoid, we cannot reach. And still, if we have to do that, I will show you the video. This is a bilateral facial palsy.
आंख बंद कर, जोर से हो गया। अच्छा, माथे पे थ्योरी डाल, आंख खोल ले, ऊपर डालने की कोशिश कर।
Complete grade 6 facial palsy both sides.
ऐसे देख मेरी तरफ, दांत दिखाओ, दांत करो, मुंह में हवा भरो, मुंह में हवा भरो, छोड़ दे।
So this is the decompression through transmastoid.
This is a transmastoid approach to decompress the facial nerve from first genu to second genu. Longitudinal fracture line can be seen transecting the mastoid bone. Now cortical mastoidectomy is in progress. The fracture line is followed medially and incus is removed to see the site of injury on fallopian canal. Posterior epitympanotomy has been performed and facial nerve is visualized in its tympanic segment. A bony fragment was found impinging on the anterior part of the tympanic segment and it is removed. As the bony fragment is reaching the first genu, this is also decompressed along with. Now, decompression is done on distal side of injury site till second genu, where a normal healthy nerve is visualized. So decompression could be achieved on both the sides of site of injury till first and second genu. Finally, the sheath of nerve is also incised. For osteoplasty, incus is reshaped as interposition graft and placed between handle of malleus and head of stapes. And the tympanic membrane is reflected back.
This is the recovery.
जोर से छोड़ दो.
It be full recovery. So transmestoid, I used to do it when I had not learned the transzygomatic antiretic approach. Now coming to transcanal inside-out approach. I do whatever the surgical procedure I do for the cholesteatoma surgery, inside-out surgery. Here we do for cases where there is a fracture line reaching up to first genu or tympanic segment. Again, pitfall is it can cause injury to the semicircular canals and stapes. And when we remove the incus, the conductive hearing loss is up to 10 to 15 dB. Now, this is roadside accident case 20 days back. Immediate complete facial palsy left side. There was a raccoon eye on the right side. Tarsorrhaphy already performed on the left side. This is raccoon eye. Grade 6 palsy there. Tarsorrhaphy already performed. So now for this is the surgery.
It's a case of post-traumatic facial nerve palsy managed through transcanal route. History of roadside accident 4 months back. Patient suffered immediate complete facial nerve palsy left side with mild hearing loss. On examination, TM found normal and patient had grade 6 facial nerve palsy left side. Pure tone audiometry showing conductive hearing loss in low frequencies and mixed hearing loss in high frequencies. HRCT temporal bone axial cuts are showing longitudinal fracture line involving squamous temporal bone in full depth, crossing middle ear and reaching medial to the ossicles, reaching up to geniculate ganglion. Labyrinthine segment seems normal. Coming to surgical steps. Otoscopy showing intact tympanic membrane. Post-oral incision is given. Posterior inferiorly based musculoperiosteal. The skin of external auditory canal is lifted up to the annulus and retracted anteriorly. Canalplasty is in progress. The fracture line is followed medially along with the canalplasty. Now, the posterior quadrant of tympanic membrane is lifted to enter the middle ear. We can see a lot of fibrosis and granulation in middle ear cleft around the ossicles. Line is reaching up to the first genu. The incus and head of the malleus need to be removed to reach the exact site of trauma to fallopian canal. Inside-out epicotomy started, and all granulations and hypertrophic mucosa is cleared along with. The lateral atic wall is drilled in anterior, superior, and posterior quadrant. In the medial wall of the atic, suprafacial cells are drilled to reach up to the first genu. The granulation tissue in first genu area points towards the exact site of injury to facial nerve by the fracture line. In routine practice, we first drill away the bony fallopian canal and then decompress the facial nerve. But in this case, as the first genu area is surrounded by granulation tissue, we need to follow the facial nerve up to that to create the right plane. And following the same plane, first genu is decompressed after clearing surrounding granulation tissue.
Now I want to take your attention here. This is the processus cochleaformis bone. Usually whenever there is a fracture, this bone falls on the facial nerve and presses it, and this is the main reason for the complete facial palsy. This bone is to be lifted always to take away that pressure from the facial nerve.
The principle of facial nerve decompression is to decompress the nerve at least 3 to 4 millimeters beyond the site of injury on both the sides till we get a healthy segment of facial nerve. So in this case, we need to decompress tympanic segment on distal side and labyrinthine segment on the proximal side. The healthy tympanic segment is visible, and now the labyrinthine segment is being decompressed and a normal healthy labyrinthine segment could be found. It's very important for us to differentiate the color difference between an inflamed and healthy nerve. The handle of malleus is being prepared for incus interpolation.
So this is the reconstruction after decompression.
It is not
ossiculoplasty. So we try to bring conductive hearing loss to as minimum as possible.
Now, it's a case.
And this is the recovery of facial nerve. Just see how the recovery happened. And I keep the record of every visit the patient comes and I take the picture and photographs. This is pre-operative. First month post-operative post-surgery.
सिर्फ उठा. Very good. आँख कस के बंद कर, छोड़ दे, नाक चढ़ा ले और माथे पे त्योरी डाल.
Recovery after 2 months.
माथे पे त्योरी डालो.
I keep training them to avoid the sick kinesis that can happen in the recovery phase by doing physiotherapy and
छोड़ दो. Very good. नाक ऊपर चढ़ाओ. ठीक है. दांत दिखाओ. दांत दिखाओ. मुंह में हवा भरो.
Till week 4 months post surgery.
माथे पे त्योरी. ठीक है. बस आंख हल्का बंद करो. ठीक है. आंख को जोर से बंद करो बिना होठ को उठाए. वेरी गुड, वेरी गुड. अब दांत दिखाओ. आंख खोल लो. नाक ऊपर करो और मुंह में हवा भरो.
This the audiometry is also improved. And this is the normal face.
माथे पे त्योरी पूरी.
Just
छोड़ दो.
see every bit of function is come back.
जोर से मीच लो. वेरी गुड. छोड़ दो. नाक ऊपर ऐसे कर. बहुत बढ़िया. दांत दिखाओ. हाँ, और मुंह में हवा भरो.
And this is the autoendoscopic picture. And this is last but not the least, the transzygomatic anterior radic approach, because most of the cases, almost all the cases wherever there is a transverse fracture line, first genu and the labyrinthine segment is the affected one most. Rather than coming from post-oral route, if we come from anterior and hit this transzygomatic area, then it is the straightmost pathway to the labyrinthine segment without any important structure in between. I will show you how we do it. Patient lies in a lateral position. Surgeon sits in front of the patient. And surgical steps from post-oral side, I mean, either we can give post-oral incision or endoral incision. Extra-aortic canal skin is retracted anterior superiorly. Tympanic membrane with handle of malleus is retracted inferiorly from 3 o'clock to 9 o'clock position. Incus is taken out. Surgeon shifts and sits in front. When we sit in front, we start the drilling in anterior part of middle ear at root of zygoma. I'll show you through the video. Now the cells which come in the way before we reach the facial nerve are zygomatic ear cells, supratubal, attic, supralabyrinthine, and suprafacial from lateral to medial side. We reach the facial nerve, delineate the level site of injury, decompression or anastomosis done, reconstructive procedure done. Again, this is a bilateral facial palsy where there is a fracture line going there. And this is the patient. Left side is slightly showing some kind of.
नाम देखो. back.
now see. This is posterior side, this is anterior, this is root of zygoma. Superior, inferior, posterior, anterior, this is right side.
The skin of the external auditory canal has already been lifted via the postoral or end oral route, and tympanic membrane with handle of malleus is lifted from 3 o'clock to 9 o'clock position and retracted inferiorly. As we have to reach the labyrinthine segment, the incus and head of malleus are also to be dislocated and removed. From here, the surgeon shifts and sits in front of patient and starts drilling in the root of zygoma from lateral to medial.
So just see, this is anterior part. I am sitting here. Usually we go from that side. I am going from this side. This is the triangular bone of zygomatic root, which I am drilling. I'll go straight medially and I will reach the labyrinthine segment.
From here, we drill into the anterior attic without any important structure coming in the way. The lateral wall of attic in anterior, superior, and posterior part is drilled away. As we reach the medial wall of the attic, we start drilling the supralabyrinthine and suprafacial cells to expose first genu and labyrinthine segment. As we are drilling anterior to the ampulla of lateral and superior semicircular canal and stapes, so no risk of injuring them. Also reaching the geniculate ganglion and GSPN is so very easy through this technique. Decompression of tympanic segment and second genu is in progress, and if needed, we can also decompress the mastoid segment through this approach. In the area of first genu, when the facial nerve takes up.
So see, this is tympanic segment, second genu, stapes, lateral semicircular canal, superior semicircular canal. So we are not going to injure. They are far away from us because this is the labyrinthine segment which we have decompressed.
Posterior turn proximally, there is a block of bone between the labyrinthine segment and superior semicircular canal ampulla, which needs to be drilled away to expose the labyrinthine segment. This step is straight and very simple with transzygomatic anterior attic approach, whereas in other approaches where we come from the posterior side, there is always a risk of injuring the ampulla of lateral or superior semicircular canal. So chances of incomplete decompression of the labyrinthine segment. Now the nerve sheath is being incised for complete decompression. The labyrinthine segment is clearly visible. Reconstruction is done by placing tragal cartilage graft to repair placed back over head of stapes.
So this is reconstruction and this is the recovery.
अच्छे से आंख से बंद करना, ठीक है, दांत दिखाएं अच्छे से, ठीक है,
this is the post surgery video. Again another case. So I think that is, So finally, the post-surgery outcome depends on time of surgical intervention, extent of damage to facial nerve. Best results are when we do it within 30 days, still excellent in 6 months, fairly good results in 6 months, but after which recovery becomes incomplete and defective due to collagenization taking place. There can be simple misdirection, there can be synkinesis, complex misdirection. So many complications can happen if we don't do the surgery there and then only. And this is the last slide showing that though neurosurgical management of head injury always takes the first seat, but initial assessment of facial nerve and corrective measures to be started as soon as the condition of the patient permits. 75% cases facial nerve injury recovers with conservative treatment only. 25% requires surgery and reanimation. And longitudinal fracture, incomplete and delayed facial nerve injury is best prognosis. Transverse fracture, immediate complete facial nerve injury require immediate surgical intervention. No single approach to all condition. Customize the surgical treatment. If not rightly performed, the only chance for recovery of nerve function is lost. Patient has come to you for that only chance. So these are all my books which I've written over the time. I hope you could have a hand on them. And this is Life Takes Full Circle. Last slide showing this is in 1991. I came and joined this institute. And over the years, I have gone through such beautiful phases of my life. And ENT has given me everything. Thank you very much.
Loud applause even when we are nearing midnight, madam.
Thank you, yeah. Thank you.
Thank you very much. And
So
it
it
was
has been
wonderful. 3 lectures, though concise also the last one. But we got to learn too many things from it. Thank you very much.
Thank you, Vaibhav. Thank you all for waiting there and listening to me. I value and respect each one of you for waking up so late, and we all could enjoy. I hope I have so many videos if given time, and we can do these lecture series, such beautiful, comprehensive with audio, so that you can see how different situations can be handled in different way. Sorry, I have been fast in telling some things because there's so much to tell and to keep in time. Thank you, Vaibhav. Thank you, Diana.
We will have a look at the remaining videos when you come over here personally.
Oh, definitely will come and do something good. Thank you.
Yes.
And good night, everyone. It was nice interacting with you.
Thank you, madam. Good night. Bye. Thank you. Thank you, Dr. Diana.
Thank you, Dr. Hapalia.
Bye, Diana.
Thank you, Doctor.